is going to go over basically how one of the major important functions of the lung, which is transporting the gases and eventually getting into the bloodstream. Okay, so how does the actual important gases are transported in the blood? Okay, one is going to be a discussion on oxygen, and then the other one's going to be a discussion on carbon dioxide. Those are the two essential gases that the blood has to transport efficiently to basically get it into the cells, and as well as to remove the waste products, which is usually CO2, which is a volatile acid. Now, oxygen can come in two ways in your bloodstream. It can come as a dissolved form, okay, which we usually measure as the PaO2, okay, which is the arterial oxygen content. Okay. The dissolved oxygen value is actually inadequate for survival for a human being. Other lower life forms can actually survive with dissolved oxygen in it just fine. They don't really require hemoglobin. But anything that requires a lot of motion and a lot of activity like humans do, then you really need to have something else to carry the oxygen around. Okay? Simple dissolved oxygen follows Henry's law, okay, which is pretty much a simple law and shows you how the factor can be very much linear and flat in its action. The actual value of how much blood it can be dissolved is actually the PaO2, which is the arterial oxygen content, times 0.003 milliliters of oxygen per 100 milliliters of blood. And that's not a heck of a lot, okay, when you look at the overall content. When you look at the oxygen dissociation curve later on, we'll show you that the actual proportion of the content that's in the blood is extremely small and is not adequate. Now, as for the main carrier of oxygen is going to be the hemoglobin. Okay? In the sense of an adult, you're going to have hemoglobin A, and that's your major form of the oxygen carrier. Now, the hemoglobin is actually found, of course, in your blood, inside your red blood cells. So without adequate red blood cells, you don't have a good carrier for the hemoglobin. Okay? So you destroy the red blood cells. In essence, you're destroying the actual carrying capacity of the blood. So one of the tests that we undertake constantly in the operating room is that we're checking all the time the hemoglobin level. Okay? If you check the hematocrit level, hematocrit is actually a percentage value. Okay? Hematocrit looks at the number of particulate matters to overall plasma volume. So it can give you sometimes abnormal values in certain kinds of conditions that are not consistent with the hemoglobin value. So really the more important number you had to say between hematocrit and hemoglobin, it's always hemoglobin. So I always use that as my main source of information. The actual molecule is actually very complex. It's made out of proteins. These proteins can actually have genetic variability, and you undergo different genetics in your life. When you're born, you're actually born with a very high oxygen-capable hemoglobin called hemoglobin F, which is fetal hemoglobin. Fetal hemoglobin has a much higher propensity to hold on to oxygen than adult hemoglobin, and that's good because it extracts the maternal blood oxygen from the mom and pulls it across into the placenta and basically gives it to the fetus. As you become an adult, your hemoglobin F converts into hemoglobin A. There's, of course, different disease processes that can actually affect the hemoglobin quality, and that will be talked about later on. Now, the actual molecule that actually holds on to the oxygen is actually iron. Okay, iron is the important component that is actually being held by the hemoglobin molecule. The way I want you to think about a hemoglobin molecule is imagine it as basically a catcher's glove. Okay? And in the middle of the catcher's glove, you have a magnet that is going to grab onto a baseball that's made out of some kind of metal that's magnetic. So as long as you can get the hard ball, which is the ball, into the glove and it'll hold that ball. Okay? What's interesting about this hemoglobin molecule is that it actually changes configuration just like a catcher's glove. Okay? It can open in certain situations, and at other times it will close to prevent the oxygen molecule to come in. So it helps to unload the molecule. So So different situations can actually configure the protein in a different manner to either allow the oxygen to be uptaken more than other times. But ultimately, the most important compound is the magnet that's inside the glove. In this case, it's called the ferrous iron. Okay? That's what actually will take up oxygen. Okay? If you convert the ferrous iron into a ferric form, okay, then the hemoglobin molecule, even if it's good quality, it will not work. Okay? So certain compounds can actually convert the iron from being magnetic to non-magnetic, is basically the analogy. Okay? That conversion from ferrous to ferric form, the way you remember it is the us, or the OUS, is accepting us, okay? And if you put eric ferric is saying is incompatible with oxygen. So ferric's incompatible, so for I. So the conversion of ferrous to ferric is caused by a molecule, it forms a molecule called methemoglobin, okay? And methemoglobin is something that you have to understand, because a lot of drugs that we give can actually convert this situation very easily, okay? One example of that is nitrites. So nitrites, like nitroglycerin, can do this, okay, at very high doses, but it's unusual to see that. The other one that can also convert and form methemoglobin is nitroprusside. So nitroprusside is an also important factor in it. The other problem with nitroprusside is it's a thiocyanate, okay, so it's got cyanide in it. So you can get cyanide toxicity with nitroprusside. It's a little bit different than this problem. If you're looking at the thiocyanate toxicity of nitroprusside, that poisons the mitochondria at the cellular level, so you actually get an increase in oxygen levels in your venous return. That's one of the ways you can actually pick up that somebody is toxic with nitroprusside. But it will also form methemoglobin. Certain antibiotics called sulfonamides will also cause this, and acetylenolides will also do this. And specifically, one of the ones that I particularly worry about, and actually we've taken off our formulary here pretty much. You have to find it in the difficult airway cart. It's because most people don't know this, but hurricane spray, which is made of acetylene, can cause this rather easily. And what will happen is if you work somewhere where people don't understand this, they think, well, you know what? What the bottle says to do is acetylene is used as a local anesthetic for the mouth. So you're supposed to only spray twice, and that's it. So, if you're told, this stuff really works good with 2 sprays, what are you going to want to do? Right, more is better, right? Let's give them 20, Sit there and spend the whole bottle in the patient, okay? I've seen it done, okay? And then as soon as it's done, what you see is the saturation goes down like a rock. Okay, all of a sudden you're down at 85%. And everybody's scratching their head and going like, what's going on? Why does the saturation fall like a rock? And the answer is because they just gave this person acetylene, and now the actual irons turn from ferrous to ferric. And it's true. That's a real true sat that you're seeing on the board. 85%, and I've seen as low as 76% because somebody just was almost emptied the whole bottle individual. That's not a good thing. Okay? Now what you do to convert the iron back is you give a certain dye. Okay? The dye is called methylene blue. Okay? It's pretty amazing when you do give it to somebody that has this kind of problem. It'll convert the ferric form back to ferrous. Okay, so methylene blue is the reversal agent of this. It doesn't mean that you can spray away and then give methylene blue and cause them to think everything's fine. No, because if you really overdose somebody really high, it's almost like competition that you're doing, and you can only give so much methylene blue. So sometimes you can't reverse it adequately. So don't really do that. It's not smart. Now, the way I want you to think of hemoglobin is think of also as a truck. Okay? It's a very rapid transfer system. Okay? And the truck analogy kind of works very nicely because it gives you an idea conceptually about how oxygen is carried. Okay? If you think of your bloodstream as basically a superhighway, and inside that superhighway you have actually trucks on it which in this case are the red blood cells, which contain the hemoglobin in them. You understand that the hemoglobin actually is very efficient in carrying blood. It's not a regular truck, it's actually an extended truck. So it actually carries 1.39 in value times how many trucks, which is the actual number of hemoglobins that we can do in a blood test. And then we actually know how full the trucks are by measuring what's called the saturation. The saturation is just a percentage of how full the truck is. Okay? So if you conceptually understand all that, it becomes, you can carry that with you at the clinical. So the value that we give you to know for the test is 1.39 times the hemoglobin times the saturation. If you read the British press, it'll be 1.34 times the hemoglobin times the saturation. Don't get caught up into the factor. Okay? There's different reasons that there's different values, and I think I talked about that last week. So now the next important concept is not only is the oxygen being carried by the hemoglobin truck, but the hemoglobin truck actually has a way of changing its configuration. It's almost like a transformer truck. Okay? It can do different things under different conditions. Okay? The interaction of this is described by what's called the oxygen dissociation curve. And you need to start to begin to understand that to basically understand how the affinity of oxygen can actually be altered based on the environment that this hemoglobin truck is traveling in. Okay? So I'm going to give you another analogy. I'm going to give you an analogy of two areas. Okay? We're going to imagine that the lung is a nice villa out into the countryside with beautiful blue skies, nice cool weather, you're close to the mountains, so it's just an absolutely gorgeous place. Okay? And that's the lungs. And then we're going to transfer material from there, and we're going to go down to the city. In this case, a city that's pretty polluted. It's producing has a lot of manufacturing, so it has, big manufacturing companies. So they're producing a lot of smoke, they're producing a lot of heat, okay? And they have a lot of workers to fill those factories. So those are three parts, okay? So now let's convert the analogy into what we're looking at in the sense of how oxygen dissociates. When you get the oxygen truck inside the lung, okay, that's your villa in the nice outside world, the environment tends to be cooler, okay? The CO2 is the lowest it is because you're around plants that are absorbing the stuff, okay? So in this case, your lung is extruding it out, okay? So the CO2 is lowest, okay? And the oxygen value is at the highest in the lung. So as a consequence, the truck basically fills up with oxygen in your lungs. The system is set up for a high affinity for oxygen due to a high pH, a low CO2, low temperature. Okay? Take that truck now, and there's no people. So there's no what's called 2,3 DPG. Because, when you go out in a vacation, you don't see a lot of people around. Because everybody's working. Only a small percentage of the workforce is actually available to go to the villa. So you only have very, very little 2,3 DPG. That's what the people are. Now you take that truck, you take it into the superhighway. Now you're traveling down the road. Okay? Eventually you get to the city. Once you get into the city or the tissue, okay, then you have a situation where you have a lot of workers. So you have a lot of 2,3 DPG. Those workers are going to peel the oxygen out of the truck. Okay? The other thing that's going to change the truck to make it more likely to give up the oxygen is that there's a lot of CO2. There's a lot of smoke in the area. Okay? So the oxygen is being come off. The pH is also low because of the elevated CO2 levels, which alters the pH. Okay? And the other thing that is a byproduct of the factory is heat. And also heat will unfold the molecule and make it more likely to let go of the hemoglobin. Okay? So those are the things that are going to be important to actually dissociate your oxygen off the oxygen out of the hemoglobin. Okay? So that's the alteration, the affinity to oxygen. Now, what I'm going to show you next is the oxygen dissociation curve. Okay? When you look at the oxygen dissociation curve, most people always remember two of the three values. But there's actually three axes on the oxygen dissociation curve. Most people just remember that there's two, which is the PaO2 and the saturation. On the other axis, which is also on the y-axis, but it's on the other side of it, is the actual content, or what's called the CaO2. The content is a combination of PaO2 times the saturation times the hemoglobin times the value of 1.39. So it's a combination number. So that's what CaO2 is. Okay? So here's your oxygen dissociation curve. Here are your three axes. Okay? You have on the x-axis, you have the PaO2 value. Okay? The normal PaO2 usually goes up to around 100. That's not 100%. That's 100 millimeters of mercury. Okay? So that's a value that we obtain by drawing blood from your arterial gas. Okay? So it's a true value. The other side, the y-axis on this side, is the actual hemoglobin saturation. That's a percentage. The highest you can go on any hemoglobin saturation is 100%. And the lowest you can go is 0. So it's between 0 to 100. Okay? On the other hand, if you look on this side, this is your oxygen concentration, or the CaO2. Okay? That's the CaO2, the oxygen content in your bloodstream. That's a calculated value. Okay? Now, here's what confuses people, and I'll show you a picture of it here in a minute. But this value here is correlated to this value here, the 100%. Okay? The maximum you can always reach is 100% of what the oxygen content can carry. Okay? If I begin to lose my amount of hemoglobin, can I still be 100% saturated? The answer is yes. Okay? The problem with it is that your content just decreases. So the curve will actually shift downwards, is what I'm telling you. But it'll still remain at 100% if you fill the truck up 100, into the 100% value of oxygen. Now, what I want you to pay attention to is there's two curves here. Okay? The bottom curve in this linear format is the actual dissolved oxygen. That is your actual oxygen is dissolved in the plasma. As you can see, this value is almost insignificant. And that's why we don't use it in a clinical formula most of the time. When we actually take the clinical formula, we take the PaO2, and we just don't even add it onto our equation. We just do the 1.39 times the hemoglobin times the saturation. And we don't add the plus 0.003 times the PaO2 because it's not clinically important. Okay? It's not a very big part of the content. So now let's look at the oxygen dissociation curve. This is the oxygen dissociation curve. Okay? Things about the oxygen dissociation curve that you're going to need to know for your test is you need to be able to plot points over time on this curve. Under normal circumstances, if I tell you that somebody's PaO2 is at 60, what should the saturation be? And the answer should be 90. The way you memorize it is really simple. Take the 6 and flip it upside down. What does it become? A 9. Okay, that's how I remember it. You keep it simple. I remember that for 20 years that way. Okay, so 60-90 rule. As you go down, these points, you have to be able to plot them. Okay, and I'll show you those numbers that I want specifically in the next slide here in a minute. Now, the other thing that I want you to understand is this oxygen dissociation curve shifts. It shifts into either a left or right direction. You can shift it this way, or you can shift it this way. Okay? This way is to the left. This way is to the right. It's from the view of the person who's looking at the paper. Right, left. Okay? Right. Sorry, I'm doing the opposite. Right, sorry. I'm sorry. Brain fart. That's the bad thing about being left-handed. Everything to you is right. So that's the way I do things, sorry. Anyway, so it always is to the point of view of which way you're looking at. So this is right shift, left shift, okay? Now, what it basically means when you're shifting this curve is just describing what's happening to the molecule itself in the environment that it's at, okay? If you see a right shift, okay, what's happening is the oxygen is no longer being held by the hemoglobin molecule. So let's give an example, okay? Let's do the 60-90 rule first. If you're in the lung, the normal value should be around 90% saturation, okay? That's in the lung. But as you're going out to the tissue, what happens is that for that 60 PaO2 value, now you're down to almost 20% saturated. So you've changed the way the oxygen molecule, or the hemoglobin molecule, is holding on to the oxygen. Okay? So when you shift towards the right, you're basically changing the hemoglobin so it does not want to accept oxygen anymore, and it wants to dump it off. Okay? On the other hand, if I shift it to the left, I'm increasing the affinity tremendously for oxygen. An example of what that red shift would be something like hemoglobin F. If you had a kid was born with hemoglobin F and it doesn't change to hemoglobin A, that kid will have a higher power to hold on oxygen. And that's not really good. Okay, and the reason that's not really good is because when it gets to the tissue level, it's not able to release the oxygen. Okay, so you want to be able to shift that hemoglobin molecule from being holding the oxygen to then releasing it. Okay? Now, if you're looking at the baby, why does the baby have hemoglobin F? You know, why is it up here? Well, because mom's here. Mom's line's here. So which way is the oxygen going to go? The oxygen is going to go to the baby. And that's why babies have a higher affinity to oxygen, so they can actually extract it from mom and then give it to itself. Now, the reason the baby can do fine with that is, guess what? Guess what his metabolic activity is like? Is it really high? He's very low. He's sitting inside of a salt ocean. He's just sort of swimming, you know, and just doing nothing, okay? So, yeah, his metabolic activity is very low, so he can tolerate that just fine. All right, so this is to make sure that you understand the shifting that takes place and why it takes place. Yes, sir. This value here is the CaO2, okay? And the CaO2 is basically an equation that equals 1.39 times the hemoglobin times the saturation, okay, plus 0.003 times the PaO2. Okay? That's the equation for that one. Okay, but we don't use this part at all in clinical. Okay, so instead we just use the top part. If you want to do that for a test, that's such a close number, you know, that nobody's going to be picking that difference, I don't think. Okay? So the curve can shift up or down based on the CO2 equation, is the oxygen dissociation curve, which is what I was just showing here, 0.003 times the PaO2. Okay? I'm glad you asked that. That's the next sheet. Okay? And I'm going to show you the examples of that. Okay? The reason this is important for you to understand is that this is like an example of a person who is a Jehovah's Witness, okay, who does not want to have blood products. Okay? And what will happen is you'll start with a hemoglobin, let's say, of 15, and by the time you're finished with the case, a person's lost a few units of blood. Now they're down to hemoglobin of 10. Well, they're still 100% saturated, but look how much carrying capacity has been reduced. It's gone from a carrying capacity of around 20 milliliters per 100 milliliters of blood. Now you're down to maybe about 15. But if your hemoglobin drops down to 4, now you're down to here. So you're down to the critical level. You're down to 5. Okay, in that point, I don't care how much you give that person to maintain their perfusion and blood pressure. If you're down that low of oxygen levels, the tissue begins to die. And you know it because you'll see the metabolic acidosis, because the lactic acidosis from anaerobic metabolism will start taking place. And no matter what you do, you can't keep that person alive. Okay, I've tried, and it doesn't work. Okay? The only thing that works is you've got to give that person some way of carrying oxygen around. So one of the things that you can do in desperation is you can give them what's called perfluorocarbons, okay, which is basically a liquid that you infuse into the IV, and it will actually hold the oxygen at a higher content, and it will actually work. Okay? The problem with it is it causes a lot of problems. It causes DIC, and it's just a nightmare in itself. But when you're desperate, you can do some interesting things. Okay? But without really the hemoglobin trucks, the content falls off, and that's what we're trying to show you here. Don't be fooled by 100% saturation. That's only part of the whole answer. The actual more important concept is content, CaO2. Okay? Not enough content, patient's not going to do well. If you see somebody with 100% saturation and you see the hemoglobin's 4, you better start transfusing. Okay? You're way behind the 8 ball. Okay? Curve can actually shift to the right or left. The right shift is the one that we showed you before that decreases the affinity to oxygen. This is where the trip into the city is the right shift. Okay? So anything that causes an increase in hydrogen ion concentration, which causes a decreased pH. Okay? This is usually related to CO2, because as you're getting closer to the manufacturing centers, your CO2 is rising and your pH is decreasing as a consequence. The other thing is that also causes the right shift is increases level of 2,3-DPG, which is an end product of red cell metabolism, and increases in the areas of low PaO2 as well, and increased heat also shifts the hemoglobin to the configuration where it doesn't hold oxygen very well. As you approach the lung more, it shifts the curve back to the left again, back to its normal curve, where the values that we give you on the test are the lung. Okay? We're not really expecting you to say, okay, what happens at the tissue level? We really want you to know what's happening with the oxygen dissociation curve at the lung. Okay? When you get to the lung, you get the left shift, which is due to decreased hydrogen ion concentration, which leads to an increase in pH. You see a decreased PaCO2, of course, because the lung is actually removing the CO2. You have decreased levels of 2,3-DPG and decreased temperature. So the actual curve will shift depending on these different environments. The top curve shows you what happens with the temperature. Normal individual is around 38 degrees once they get into their bloodstream. If you look in the lung, it can drop down significantly in temperature, which increases the oxygen dissociation curve towards the left. Okay? And then towards the right, when you get down to your skin, to your core temperature, it may increase dramatically, especially in fevers. Then it shifts to the right considerably. You can see the CO2 curve does the same thing as we talked about previously. As you decrease the actual CO2, the shift curve takes place, shifting to the left. And as you go towards the cells, you decrease it, you shift it towards the right. And you can see pH the same thing. So these curves, you have to understand which way they're going to go, left or right. Okay? Always remember, it's looking at it from the standpoint of what you're looking at on the paper. So just put your hand on the paper, okay? Right hand, left hand. Okay? Which way is it going? Left is going towards my left hand, right is going towards my right hand. Okay? Now the oxygen dissociation curve has to do with a certain degree with the Bohr effect, which I'll talk about in another discussion later on. I'm going to sort of skip this for now. I think it just confuses the topic. Now, one of the things that I want you to really pay attention to, this is what I expect you on the test. If somebody tells you that their PaO2 is 60, you should expect the number to be around 90. Okay? The PaO2 is around 40, and it should be 75% saturated. And then the P50 is where your saturation is at 50%, and that's at 27 millimeters of mercury for an adult. And that's a number you have to memorize. That third one specifically is very important because they always tell you what the P50 is. That P50 will shift depending on the hemoglobin quality. Okay? So that's an important number to know. Okay? Now, once you get above 100 millimeters of mercury, most people now reach 97% saturation or greater. If I tell you that I'm at 200, what's my saturation going to be? What happens when I hit 300? I'm still at 100% saturation. There's the limit. That's the problem with just looking at sats. Okay? You don't know what the PaO2 value really is once you're above 100%. Now, why is that important? Clinically, it's very important to understand what the PaO2 value is in association with the saturation, because it tells you how healthy the lung is, how well is diffusion taking place across the alveolar membrane. So if I tell you that if somebody has a PaO2 they have a saturation of 100% on a PaO2 of 100, is that okay? And the answer is you don't know, because you don't know what the alveolar oxygen content is. If I'm giving you 100% oxygen to that individual, the PaO2 in the bloodstream should be 600. Okay? And that's the real issue. You have to sort of know what the PaO2 value to tell you how well diffusion is getting across the membrane. And that's a really important concept. Most students forget that. When they get to clinical, they'll say, well, you know, the saturation's okay, the lung's fine. No, you don't know that. You could actually be main stem intubated, and you could be, your PO2 values could be down as 200 and still be 100% saturated. Because once you get above 100, usually 100% saturated at that point. Yes? The arterial O2 content, in the sense of measuring how healthy the lung is clearly important. Okay? And you have to correlate that with your alveolar calculated number. Okay? You have to know the AA gradient. Okay? If you're just watching saturation, saturation can fool you. Because once you hit a certain PaO2 value of, let's say, 100, you're not going to get any higher in your sats. So you're not going to have any clue beyond that what's really happening. And if you're riding somebody on 100% oxygen during the whole case, you're never going to find out that you're main stem intubated. Okay, you could be main stem intubated with a 60% shunt, and you're still going to be 100% saturated if you're on 100% FiO2. And you're not going to even pick it up. Okay, you could have a mucus plug, you're not going to pick it up. You'll pick it up once you when you extubate the patient, and everything goes to heck, because you're no longer, now you're on room air, or you're down to 30% oxygen. So that's the real danger of going to 100% oxygen. And some people forget that. And you'll get to clinical and you'll see people who will tell you, well, nitrous is bad, so I'm going to just use 100% oxygen for all my cases. That's beyond stupidity. I mean, I just don't understand why people do that kind of stuff. But you'll see it done all the time. Now, if you want to do that, what my argument will be is drop down your FiO2 as low as you can go, so you can now use the saturation as some form of monitor to help you figure out that there's something wrong with the lung. Okay? If you see that somebody saturation goes from, you're on 100% FiO2 and your saturation is down to 96%, that's very serious at that point. You've lost 70% of the lung function at that point, possibly. Okay? And if you're not paying attention to that, because you say, yeah, it's 97, so it's normal, you've lost a big part of what's going on in that case. Okay, so one of the things that if you don't believe in nitrous, if you somehow believe that nitrous is a bad agent, then you should be using a lot of air. Just make sure that you turn on the air and drop your FiO2 down to around 40% if you can. Most of the time we ride here with around 50% nitrous oxide is what we do most of our cases here. At least that'll give you a sense of if you main stem intubate somebody, you will pick it up pretty quickly. Okay? Please don't. The other thing that students will make the mistake in is they'll see the saturation will fall, and they will immediately increase the FiO2. And I'm not going to fault you for that. That's the right thing to do. You have to deliver oxygen to the patient. Okay? But that just does one thing. It masks the problem. If you don't know what's caused it, and you've just increased the FiO2, all you've done is hidden the problem for temporary. It's going to come back to bite you if you don't fix it. So at that point, you've got to now go through the steps of figuring out why is this person desaturating. Okay? Listen to breath sounds. Okay? Make sure the tube didn't get pushed on you. The patient could have been put into a deep trundumbar position, and the tube now is down into the patient's right main stem. That's the most common problem. It could be that the person also has developed a mucus plug, and you might have to do a bronch on the individual. Okay? The patient might have aspirated on you on induction. Okay? The patient might be developing atelectasis. Okay? The patient might be developing a pneumothorax. You have to pick it up by looking at your peak inspiratory pressures. If those are rising dramatically, you may have a tension pneumothorax developing and you're missing it. Okay? So just giving the FiO2, increasing it, just masks the problem. And that's what really you have to get in your mind, because you've got to be able to differentiate the two. Does that make sense? Now, carbon monoxide is an infrequent enemy of ours, which is good. But carbon monoxide has a big problem in the sense that it used to, if you work in a mission or you go overseas, that sometimes some kinds of our bara lime, not so much our bara lime, but our soda lime, will actually form carbon monoxide. Okay? If you expose soda lime for high FiO2s for prolonged periods of time, it'll actually form carbon monoxide. Okay? Because it dries the agent out. Okay? The good thing is our CO2 retainer now doesn't have that issue, so it doesn't conform into carbon monoxide anymore. But historically, it's something that you may still, if you go overseas, it may be something to consider. So you want to make sure that you shut off your oxygen through your machine at nighttime so that doesn't form this carbon monoxide in the morning. The patients that were developing these problems would be the first case in the morning. They were actually getting carbon monoxide poisoning. Okay? And the people couldn't tell because the saturation looks actually adequate. When you open somebody's mouth with carbon monoxide poisoning, they have a strawberry tongue. They're bright red in their tongue, which is always inconsistent with what's going on because the saturation is around 96%. And true saturation can be a lot lower than that. You have to actually do what's called a SaO2. The SaO2 is actually measured, okay, versus pulse oximetry measures it via plethysmogram and using light. So pulse oximetry gives you a mixed value of a combined carbon monoxide level with oxygen, so you really don't know what the real saturation is. Okay, that's what the difference between SpO2 and SaO2 is. But carbon monoxide is 240 times more affinity to hemoglobin than oxygen. It shifts the curve to the left, basically causing more difficult oxygen unloading. So it basically does not allow the oxygen to be unloaded at the tissue level. And that's the other problem with it, too. One of the ways you treat this is you can do a hyperbaric chamber, or actually the preferred treatment now is to give the person 100% oxygen and then try to get them into a hyperbaric chamber as soon as possible. Okay? What I'm trying to show you here, this is a nice visual representation of what actually happens with the oxygen, okay, as it's going through the alveolar membrane. It has to go through the alveolar membrane and the capillary membrane and the little interstitial space in between. The interstitial space is almost not of consequence. So it's basically oxygen transfers very quickly, and then it goes into the plasma where it's dissolved. Okay, that's a very small minority still of the actual oxygen that's carried. Most of it gets across right away through the red cell membrane where it is uptaken by the hemoglobin molecule and now is carried towards the tissue. Once it gets down towards the tissue level, the hemoglobin dissociates or changes configuration to allow the oxygen to dissociate from it, and eventually gets into the tissue of the cells. And the PaO2 value at the cellular level is actually very low. But mitochondria are highly efficient at actually taking oxygen and using it to be the final electron acceptor in the formation of ATP. Okay, so is oxygen a nutrient? The answer is no. But is oxygen essential? Absolutely. Without oxygen, you don't have enough ATP, no power, the cells don't work, they die. Okay? The maximum you can initially live without oxygen is around 8 minutes before cells begin to die. Usually your brain will start dying right around 5 minutes without oxygen, so it's not a very long time. The actual total content of oxygen in your bloodstream is around 1.2 liters, which actually is an incredibly small amount of volume, so you don't have much capacity. The amount of utilization of oxygen that you require per minute is around 250 milliliters per minute of oxygen. Okay, that's how you remember it. So in 4 minutes, you've consumed 1 liter. Okay? 5 minutes, you've consumed all your oxygen and you're completely depleted. Okay? So at that point, your cells begin to die. What your cell will try to do to survive is we'll go anaerobic. Okay? And anaerobic metabolism produces a byproduct of this is lactic acidosis, which causes, of course, a metabolic acidosis to rapidly ensue. So one of the ways you can actually figure out if somebody's in shock, which is a lack of perfusion to cells of oxygen, is always to monitor for what's called metabolic acidosis. If you see metabolic acidosis, always worry in the back of your mind, hey, I'm not perfusing something. There's something not being perfused and not enough oxygen is being delivered. And that's your big concern. That's the most important primary drug that you deliver every day in the operating room. Nothing else is important. Fluorine, nitrous, no. Oxygen is the #1 drug. You forget to deliver that for 5 minutes, game's over. Let's go on to the next discussion, which is carbon dioxide. Carbon dioxide is carried in the bloodstream in a tremendous amount. You have around 120 liters of carbon dioxide that's carried in your bloodstream. Okay? Now, carbon dioxide is carried in 3 ways. Okay? Partly it's dissolved, which is a very small percentage. It accounts for, on the arterial side, only 5% of the total carbon dioxide that's carried in your bloodstream is dissolved. When you look at the venous side, it accounts for about 10%. Okay? So these 2 values are different. The most important compound that's carried in your bloodstream of CO2 is bicarb. Remember, bicarb will convert into hydrogen ion plus bicarb will form carbonic acid, and carbonic acid then breaks open into CO2 and water. So it is the same molecule in a sense. Okay? So CO2 is mostly carried in your bloodstream in the form of bicarb, especially in the arterial side. And the last one is a bound carbamino group, which is a protein, which is an amino acid, of course, that binds to carbon dioxide. Carbamino group forms 5% in your arterial side, and it comprises around 30% on the venous side. So CO2 is basically in 3 forms. Dissolved, it's 20 times more soluble than oxygen, but it's only 10% of the total carrying capacity when you're looking at the venous side. I mean, why are we talking about the venous side? Because that's the most important one where we're saying carrying. Okay? The arterial side doesn't carry CO2 in the sense of what it wants to extract. It's taking it back to the cells at that point. Okay? So it doesn't want to do a lot of that. Instead, it has a lot of bicarb in it. And it's going back to the cells to try to neutralize the pH of the metabolic factors. But what's carrying away from the cells is the venous side. And that's where the discussion usually lies in that area. And you can see that a great percentage of it, not a great percentage of it, but the smallest component of it overall is the actual dissolved CO2, which is around 10%. Okay, so that's not very effective. Okay, so if you were to take away all the bicarb out of the system, which you could have a hard time doing, but if you did that, if you lost your kidneys, which is one of the reasons that you would start beginning to do that, then the person gets acidotic very quickly, and you start losing the ability to carry CO2 correctly in your bloodstream. What you see is that dissolved CO2, once it gets into the plasma, it'll stay partly dissolved, which accounts for about 10% of it. But the other thing that's going to do is it's going to rapidly break down using an enzyme called carbonic anhydrase. Okay? Carbonic anhydrase is going to convert the CO2 plus water into carbonic acid, which is H2CO3. So the red cells are the most important location for carbonic acid, as well as the kidney. There's 2 places that the body has high levels of carbonic acid, in the red cells and in the kidney. The carbonic acid, without this enzyme, okay, you would not get a rapid reaction to form carbonic acid. It's normally CO2 to water to form carbonic acid is very, very slow. So that enzyme is critically important for that to take place. That's why the carbonic acid is not taking place out here in the plasma. It's actually taking place inside the red blood cell. Once it forms in the red blood cell, okay, the carbonic acid, okay, is converted into hydrogen ions plus HCO3, which is bicarbonate. The bicarbonate is allowed to go back into the plasma, but the hydrogen ion is going to be very important to bind to hemoglobin. Okay? That binding to hemoglobin is going to alter the hemoglobin's efficiency to allow allow O2 to come off and to allow some CO2 to bind to the actual hemoglobin directly. Okay? But it's mostly that it's really changing the hemoglobin so it lets this oxygen dissociate out of it. Okay? In addition to that, the hemoglobin will bind to CO2, and that's what we call the carboamino hemoglobin. So the Haldane effect helps, which is the hydrogen effect, binds to the hemoglobin, altering its configuration, allowing the oxygen to pull out, but it also helps carry around 30% of the CO2 returning via carboamino hemoglobin. Okay, so the hemoglobin molecule is doing two things. It's carrying oxygen, and it's carrying CO2 back. Is it still as efficient as the bicarb system? Absolutely not. Okay? But it's still important in the sense that it's carrying 30%. It went from 5% in the bloodstream in the arterial side, and now when it's on the venous side carrying it back, so it counts for 30%. Okay? There's also another thing that takes place that's also helping state neutrality, and it's called the chloride shift. The chloride shift takes place as bicarb comes out, chloride has to go into the cell to maintain electrical neutrality. And that also helps alter the hemoglobin to actually also alter its oxygen dissociation. As you can see, the oxygen molecule will peel off more as more CO2 comes in. So bicarbonate still accounts for about 60% of the carrying capacity. Okay? And it's, again, partly the carbonic anhydrase that's responsible for this pathway to taking place. In the actual plasma, it's a very slow reaction because you don't have the enzyme there. Okay? So carbonic anhydrase causes the reaction to occur rapidly inside the red blood cell. Bicarb diffuses back into the plasma, but the hydrogen ion cannot. And the chloride that shifts into the cell to maintain electrical neutrality is called the chloride shift. Now, the hemoglobin binding to the hydrogen binding to the hemoglobin is very important for reducing it and having a higher affinity to unload oxygen and load CO2, which is what's called the Haldane effect. The way you remember it is H for H, hydrogen to hemoglobin. Okay, the Haldane effect is basically helping alter the configuration of the hemoglobin to basically accept CO2 better and to not accept oxygen very well and to basically let it be released. When you you alter this hemoglobin molecule, it forms carboamino compounds, which accounts for 30% of the carrying capacity. Carboamino basically simply is hemoglobin that now has got the hydrogen ion attached to it, which then now accepts CO2 as a consequence. Okay? So that's a carboamino compound. Okay? That's the 30% of the carrying capacity that's venous return, and CO2 ends up combining with a terminal amine group in blood proteins. Okay? So it's not so much the actual iron component, but it's a portion of the hemoglobin molecule that is binding to. So it's not binding at the same site as the oxygen site, okay? Which is an important concept, which I keep forgetting to tell people sometimes. So what you see is that CO2 diffuses in the bloodstream, 7% actually remains dissolved. 93% diffuses into the red blood cell, where 23 binds to the hemoglobin, forming carboamino hemoglobin, which in the book says 30%. Okay? So this is slightly differences in numbers. The different books do different things. So this is more to show you how this thing actually works. 70% is converted into bicarbonate, carbonic acid by carbonic anhydrase, and then the carbonic acid dissociates into hydrogen ions and bicarbonate, and the CO3 goes out and is dissolved in plasma, and hydrogen ions removed by buffers, especially hemoglobin, which goes back to this guy. Okay? Now the last slide is this oxygen versus CO2 dissociation curve. CO2 dissociation curve is much more linear okay, than oxygen. And that's going to be very helpful when we talk about sensors. Okay? The PaO2 values compared to CO2 values are not as rapidly changing, so it's much more accurate for the body to sense CO2 when you look at it from the sense of dissociation curves. If you see the CO2 rise very quickly, it will actually rapidly change the actual content more linearly, versus oxygen doesn't do that. Once it saturates, oxygen really is not going to go any higher at that point. Okay, so in other words, once you saturate the hemoglobin molecules, it can't really get any higher. What happens with CO2, on the other hand, is it'll keep getting converted into more and more compounds that your bloodstream will carry, because it has so much more affinity to CO2. So in essence, you have in your bloodstream a capacity to carry up to 600 to 1,000 parts of oxygen in it. Sorry, 1,000 parts of CO2 in it. It can keep taking it in. Somebody has actually been poisoned to have a CO2 level as high as 500, and that person survived and woke back up. You can imagine what the pH must have been on that individual. Okay? But you know, it's amazing how the body can accept more carbon dioxide versus oxygen. Once you get to a certain limit, you're not going to get much higher in it. Okay? It's much more linear in its correlation to the actual content. Okay? So this is a correlation dissociation curve between content and the actual partial pressures. The reason it's also important is when your body senses these changes, as CO2 rises, the body's going to stimulate more, usually to breathe faster. And we'll talk about that later on in 2 chapters from now. The blood tissue gas exchange is once the gases get to the actual tissue level, the actual PaO2 value is actually very low. Okay? And it doesn't take much, just because the mitochondria are very efficient. Now, in addition to the actual content, what also is important is delivery. Okay? Delivery is a value of how fast is a truck going. If you think about it in the sense of a superhighway, if you have trucks going at 5 miles an hour versus 65 miles an hour, they're definitely going to get to the town a lot faster. Okay? So it has to be, in this case, related to how much flow is going through. In this case, we use cardiac output, which is liters per minute. So delivery, which is a D.O2, is equal to the actual content, which is how full the trucks are and how much blood is in the plasma, times the actual cardiac output. So things that will actually lead to a low oxygen delivery state will be low cardiac output states or low content. Okay? Low oxygen carrying capacity could be due to low hemoglobin, low saturation. Okay? You could be anemic, in other words, okay? Or have an abnormal hemoglobin molecule from poisoning. Or you could have carbon monoxide poisoning, where you actually affect the actual hemoglobin has affinity to oxygen. Okay? The other thing that can also lead to a low arterial oxygen content will be a low FiO2, which would lead to a low alveolar oxygen content. Diffusion problems can also cause issues. If you develop shunt fractions, okay, that could be significant in its ability to get arterial oxygen content in. Ventilation perfusion inequality is still the #1 cause of most low levels of arterial oxygen content by far clinically. You could also have reduction in tissue perfusion taking place, such as a thrombus forms in the arterial side of it, or you go into a shock states where it doesn't matter which kind of shock. Shock will be described later on in coexisting, where we talk about how perfusion is a critical factor in that. It doesn't matter as long as you don't develop, if you don't perfuse a tissue, you go into a low oxygen state issue. And the last one is you have to know is that if you cannot get oxygen into the tissue, the person will still die. One of the most efficient poisons for killing a human being is cyanide. Okay? The reason cyanide is so efficient is that it doesn't affect the hemoglobin molecule at all. It doesn't have any effect there at all. Okay? It does not affect the oxygen content in your plasma. But what kills you is the actual mitochondria get poisoned by cyanide. And so the cyanide is destroying the oxygen cytochrome oxidase mechanism in the mitochondria, and as a consequence, you cannot take oxygen. You can't use oxygen anymore to uptake the last electron. Okay. Any questions about anything so far?